Thank you all the participants for joining and showing interest in taking this up. Today, Dr. Reena will be sharing her experience in teaching medical students certain topics that we have been discussing in the last few days. So maybe you can interact and share your thoughts and your experience in between and learn from how she has done that in the past few years. Dr. Reena is working in the Department of Medical Education in CMC Vellore. She was heading the Department of Radiation Oncology in CMC Vellore, and she started the palliative care unit in 2004. And she was also the editor of Indian Journal of Palliative Care. She's actively involved in undergraduate medical education program in palliative care since the beginning, maybe starting to make the curriculum and the materials that you have seen yesterday. We have taken you through the materials. Over to you, ma'am, for today's session. And thank you so much for giving this time for us.
Good evening, and thank you for having me, and welcome to all of you. Just, if you can just put in the chat box which city you all are working in, it'll just give me a feel. I mean, online classes are never as satisfying for the teacher as face-to-face. Just give me 1 minute while I try to get this down to slideshow.
I think there is one representation from CMC Vellore also, ma'am, from the Department of Community Medicine.
Oh, that's nice. Who's that?
Dr. Sugandhi from CMC Vellore. If I remember, I think you're from Community Medicine Department. I remember seeing the nomination.
Dr. Sugandhi is from the other medical college in Vellore. Hello, Dr. Sugandhi. I hope we'll meet sometime. Yes.
Yes, madam. Good evening.
Right. So, I look forward to meeting you. I'm so glad there's someone from Vellore Medical College taking interest in teaching palliative care. And if I can help in any way, please let me know in terms of teaching.
Sure, madam.
Right. So,
since I'm traveling, I cannot talk much, ma'am.
Yes.
Thank you, ma'am. Thank you.
Right. So we will quickly look at two very large topics, teaching serious health-related suffering and teaching communication and ethics. And I'm hoping that by the end of the 1 hour session, the student whom you teach will be able to identify dimensions of health-related suffering, list some conditions associated with it, weigh benefits and burdens, and define potentially inappropriate treatment. Now, how will you design winter wear for this man? Whom will you ask to design it? So teaching serious health-related suffering to our young medical students is a little bit like asking this gang here to design warm winter wear for the man in that cold blizzard there. These guys, they're young, they're healthy, they're happy. They haven't experienced, most of them, the pains of suffering and the pains of winter. Medicine is academically exciting, which it should be, but then that's not all it is. So how do you introduce them to SHS? So I sometimes use a case scenario which they can understand a little bit, maybe vibe with a little bit. So this is a medical student who joined a private medical college 2 years ago. She's the first healthcare professional in her family. and her mother asks her to go to her uncle's house in the village and see her maternal grandmother. And her mother tells her that this grandmother had a stroke, was admitted in ICU, now she's bedridden, and you are the only healthcare professional in the family, you must go and help her. So this poor young student says, what will I do, Amma? Why don't they just admit her in another hospital? We all know how little we knew at this stage in life. So then the mom says, don't even suggest that to your uncle, because everything that he had saved for your cousin's college education went with that college, with that hospital admission. And already their business has been through bad times with COVID. And they're a respectable family. And when the neighbors tell them that the patient should be admitted in hospital, it's very hard for them to express their financial difficulties. So when the medical student reaches home, the grandmother is there with an ischemic stroke, bedbound with grade 3 hemiparesis on the left side, multiple painful ulcers, a smelly precious sore, and because of her contractures, she screams in pain when the granddaughter tries to move her limbs. The grandmother is kept in a separate room because of the smelly bed sore. And she tells her granddaughter, I can't tolerate this existence. Please kill me and release my family from this burden. So we could give a case scenario like this to our students and ask them, what are the elements of suffering here? And we hope that they will bring out physical, emotional, social, and spiritual elements, and we could classify that. And the purpose of this case study is to begin to help them to think in the shoes of the family and the patient. Then we could move on to this definition that suffering is health related, when it is associated with illness or injury of any kind, and suffering is serious when it cannot be relieved without medical intervention, and when it compromises physical, social, or emotional functioning. Then we could ask them in pairs to list 5 conditions which they think are associated with serious health related suffering. And we hope they will come up with a range of things. Then we could give them this graph and ask them to figure out how many million people will have SHS due to cerebrovascular disease like this grandmother. What is an infectious cause? What is the leading cause? So this is a nice little graph because it tells you what a spectrum of things cause SHS and a little bit about what the trends and numbers are like. And then we can introduce the concept of palliative care, that it should be focused on relieving serious health-related suffering that is associated with life-limiting or life-threatening conditions or the end of life. And then go a little deeper into the definition that it's the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially those near the end of life. And here, because we have introduced the family and the caregivers, we can stress how we need to address the quality of life for all of them. We need to draw the distinction between death and palliative care, and also that it is something that can be started early on and integrated early into care. Now, one of the good things about palliative care is that the greatest barrier to access is not affordability, unlike so many other areas of medicine. Now, when these medical students, like the ones we saw on the beach, are sitting there in their light-hearted mood and thinking, okay, what does this have to do with me? I'm not going to do MD palliative medicine. could ask them, do you think basic life support should be taught only to MD general medicine students? And, we all disagree with that. Similarly, since all of us and people in our communities and families will all face death, basic palliative care cannot be provided only by specialists. And they never know. Next week, it may be someone in their family who calls upon them for advice. So we can ask the students, maybe in a group, to list down the various kinds of help grandmother needs to improve her quality of life. Who are the people who can provide that help? And often as medical students and doctors, we don't think beyond doctors, but here they can quickly see that much of the help is actually going to be provided by the family, and then nurses, physiotherapists, and the people who are going to help them, both the professional and the family caregivers, what are the kind of resources they need in terms of knowledge, equipment, skills. So we can ask the students to come up with some answers. And if the medical student wants to improve his grandmother's situation, what can he do? What can he learn? So hopefully the students will come up with some of the urgent issues that grandmother is facing: mobility, pain, wanting to die, pressure ulcer, smell. And we hope they will look beyond the physical to a few other domains. Now, can healthcare itself cause serious health related suffering? Could you just put on yes, no, or maybe into your chat boxes? I like the double S. Yes, undoubtedly it can in each of these domains actually. And we could ask the students to list how healthcare itself could cause SHS in each of these domains. And this patient herself is actually an example. So, of course, you can have treatment toxicity, the toxicity of time, especially when, with high unrealistic hopes, patients travel far away to get treatment, and even the limited life that could have been spent with family gets spent walking around hospital corridors. Financial toxicity, emotional toxicity, dignity toxicity. And sadly, along with Bangladesh, we are among the few countries in the world where the cost of healthcare compounds suffering the most, even though we are among the countries producing the largest number of doctors. And a 2018 publication estimates that 58 million Indians, 55 million Indians are pushed below poverty annually, resulting in multi-generational debt. And mind you, the family we are talking about here is not below the poverty line. Yet there is a multi-generational impact, because what did the medical student's grandmother say in the beginning in terms of the multi-generational impact? Does anyone remember? Could you just put it in the chat box? What had happened to the family? Yes, correct. Thank you, Dr. Nidhi. Yeah. They had said that the money that was saved for the cousin's education had been spent on this 3-week ICU admission. And most families have limited pots of money, and savings are painstakingly made over years by most honest people. And it can just go like that because of the financial toxicity of healthcare. And this example, we hope, will help students understand when they become doctors that you cannot thoughtlessly keep recommending every next thing coming along, even if the family appears to be middle class. And think about the ones who are not middle class, where some sell their houses, some drop out of school, some lose their jobs because of time toxicity. People who are on daily wages, the time toxicity is potentiated. And is all this worthwhile when the disease is not curable? It's not that as palliative care we are saying we want everyone to die. It's just that we accept that we will all die and that dying is a part of life. After this, we could give them another case study. Okay? And we'll say you have this man who's come with brain secondaries to the emergency department. He has previously undergone palliative chemotherapy and cranial radiotherapy. His GCS is poor. Prior to becoming unconscious, he had repeatedly told his family not to take him back to hospital since the disease was incurable. But the family has brought him to hospital anyway, and they insist that he should be admitted in the ICU on a ventilator. So we can ask the students, so how will you respond to this case? Now, if you were the students, what would you do in this case? Can we just have a couple of answers? Here, prognosis is clear. Autonomy is clear. He does not want. Yes, we would counsel the relatives. And what would be our first step in counseling the relatives? We want the relatives to go by the patient's wishes. We know the patient's wishes in this case. What would be our first step in trying to convince the family? Yes, they need to understand the prognosis, but before that, what do we need to do?
We have to reassure the family that the patient will not suffer.
So I think before that, we need to do one or two other steps, you see. I think, first of all, we need to acknowledge to the family that we know that they want to do the best for their father. Otherwise, we can end up in a very confrontational mode. And they will think because the patient is sick, you don't want to do anything for him, you don't want to help them. So you acknowledge that you understand why they are making this request. Then you ask them what they are hoping for from the ICU admission. Okay? Because most reasonable people may have some reasons. So then let us imagine this. We know that the cancer has spread extensively, so they know the prognosis. We were looking after him at home, so that also they were doing. But when he became unconscious, my uncle told me, how can you just keep him at home? When my wife had breast cancer and became unconscious with fever, we put her in the ICU and now she is fine. Doctor, I'm ready to sell my house and do the best for my father. Don't worry about the cost. So you see, there is a very specific reason and a very specific intention why this family is asking. So then maybe we can ask the medical students to do a little ethical analysis. Let them weigh the benefits and burdens of ICU care between this elderly father with brain secondaries and the aunt who had a curable breast cancer with post-chemotherapy septicemia. So it's helpful if the students can do this themselves, because then they begin to understand the concept of futility, the implication of financial toxicity. Here is a loving son who's saying, I'm willing to sell my house. I don't want to feel that I denied my mother the best. then we can bring in the concept that disproportionate, non-beneficial treatment, inadvisable treatment, interventions that carry greater possibility of harm rather than reasonable possibilities of benefit. There might be very frequent occasions when we can withhold potentially inappropriate treatment. So sometimes, again, students are feeling guilty. How can we withdraw the best? So then we can ask them, how many of us will never die? Even the patients we cure today, sooner or later, they will die of something. And we could give them a little homework. Find a directory of palliative care services in India. What are the palliative care services in the district where your grandparents live? And these little exercises, who knows, it might help a patient somewhere. It might actually motivate a student to learn something more about palliative care. And I'm just going to request Sri Priya to play a video. Again, just to sensitize them to the fact that, their happy-go-lucky trips around the medical college is not the experience for most of the others who are coming to the medical college and hospital. So can we just play that Cleveland Clinic video, Shripriya?
Sure, ma'am. You mean the empathy one, right?
Yes, that's right. Yeah.
Okay.
Right. What are your comments on that video? Because medicine has become all in a day's work for us, we often forget what is going on inside the hearts and minds of the people we cross in the corridors, in the queues, in the OPDs. So, and the situation in our country will often be much, much worse because the degree of suffering, the degree of pain is so much more. So again, it could be helpful to give the students a little while to talk about this video or to write about it. So I think the main point I was trying to bring about in teaching SHS is that we should not be primarily preaching to them. We should be trying to enable them to feel a little bit about what all this is about and be a little willing to begin to do their part towards it, and how big the problem is. So before we go on to the second part of the evening, what are your comments or questions? In general, what do you feel? Does medical student empathy increase or decrease as they go through their training? Just put your answers in the chat box. Okay, we have many people who said increase. If you think of yourself between your first year and your internship, How many felt your empathy had increased? How many felt it had decreased? I mean, most studies show that for most people, it tends to decrease, but, and I think in this group here, we are not dealing with most people. And very often a palliative care training program, a sensitization to palliative care, and the kind of person who chooses to come into palliative care is the kind of person with above average empathy. But uh, if you look at the whole spectrum of a class or the whole spectrum of medical professionals, in general, empathy tends to come down. And case scenarios, videos, reflective exercises may be ways of trying not to lose our innate humanity. Right. So, shall we move on to the next part of the program then? Right. So, I don't know about most of you, but generally, every department wants time in the curriculum. And that's why this Parliamentarians course is good, because they have taken what is compulsory and tried to kind of put the palliative care sticker on those areas. Yes, thank you, Dr. Rukmini. We all hope that with palliative care education, empathy and the ability to act on the empathy will increase. So what I would like to do over the next hour is to just share with you some ways in which even a small department can introduce ethics or communication in the curriculum. And I hope that we will be able to look at a video in which you can identify a few key components of communication and list 4 cardinal principles of medical ethics in a case scenario. It's a little easier now because ATCOM is compulsory, so it's easier for us to fit it in then. Now, in 1997, when I was a radiation oncologist, assistant professor, radiotherapy is not a major department in the MBBS curriculum, and I had to take 2 classes for students, for MBBS students. So initially, I used to teach them about what is radiotherapy, some simple radiotherapy techniques, and common cancers treated with radiotherapy. But then pretty soon it struck me that nobody in this class may become a radiotherapist. I love the subject, but that doesn't mean others would. And wouldn't it be more relevant to teach them something about cancer pain? Because any clinician is likely to encounter cancer somewhere or the other down the line. So in those 2 classes, did a little bit of juggling around and introduced what very little I knew about cancer pain at that time, just the basics of the WHO ladder. But actually, the students found that quite satisfying and also practically helpful. And I wanted to share with you this quote, which I heard from my teacher, Dr. Robert Twycross, whose books you would have seen. So when I first heard him speak in 1995 in Vellore, I had just finished my MD and was the juniormost person in the department. But this phrase of his "start low, go slow, but do so" was very encouraging. That wherever we are, we can make a beginning, even if we have only 1 hour or 2 hours with medical students. So I just wanted to share that with you as you begin to make beginnings in your own different institutions. So when I came back from the UK with more substantial palliative care training. I was very lucky because our dean in CMC, without me asking for it, gave me 3 afternoons with medical students way back in 2002. So then again, I had to make choices. Okay, so I have put 2 lists on this column. In your chat box, can you tell me which you think is more relevant for the MBBS graduate? The left-hand column or the right-hand column? The first one or the second one? Just write 1 or 2 into the chat box. Thank you. I'm glad all of you feel that way. Although, as someone who had, recently acquired new knowledge in palliative care, many things in column 1 were exciting and interesting to me. But remember, when we are teaching MBBS students, we cannot get carried away by the excitement of our own specialties. We need to think about what their patients will need from them. So, in the 3 hours that we had with medical students, we began to do a few reflective case studies. We had a communication breaking bad news role play, and we made them go through a few ethics case studies. And then a few years down the line, some of these students started teaching communication role play. So that was in their own department. So that was so very encouraging. Now, in its recent CBME curriculum,
I'm
it is
sitting at the
easier-
table now till I finish this.
Sorry?
Ma'am, I think that was a mistake. You can continue.
Okay, sure. In its recent CBME curriculum, we are lucky that the NMC has upfront acknowledged this, okay, that it is not just clinical competencies, important as they are, that we have to transmit to our students, but we also have to give them role-based competencies to become ethical professionals, communicators, team workers, and they have given us a little time in the ATCOM module. Now, the 4 principles of medical ethics, which I'm sure you're familiar with: autonomy, beneficence, non-maleficence, justice, they're good because you know how different religions, different cultures can have practices which are acceptable or not acceptable. So there may be certain religious groups that think a blood transfusion is wrong. Abortion and euthanasia, there can be range of views. Organ donation, there can be a range of views. So these principles of medical ethics kind of transcend religion and culture. Okay. And autonomy means if a patient has a religious view prohibiting him from taking blood transfusion, then we have to respect that and see how we can work around that. The principles themselves are not clearly saying blood transfusion is right or blood transfusion is wrong. Now, when we discuss ethical dilemmas with students, which do you think is a better approach to take? Should we take cases about organ donation and stem cell research? Or should we take day-to-day clinical scenarios, the kind of cases they see in their clinics? Again, can we have a few answers in the chat box? Yes, Dr. Sitaraman, we over the course of their 4 or 5 years, we do need to cover both. But in the little time that we will get to teach palliative care, and for those of you who are in small departments, it is good to use regular clinical scenarios. Just like the case scenario we used in the previous presentation, so that they realize that ethics is not just a matter for philosophers to debate or for Supreme Court judges to give pronouncements on. Ethics is something that they have to think about every day, many times a day. And then I have, a few very simple examples. That one element of autonomy is informed consent. And informed consent is not signing or putting a fingerprint on a paper. It is adequate information to give a well thought out decision. And I often share with them an example of a patient I saw many years back who had cancer with supraclavicular nodes, had had a few lines of chemotherapy, had come from far away, and finally, when the disease progressed after 2 lines of chemotherapy and he was told it was incurable, he wept. He said, I have 2 small children and my family depends on me. I took the available treatment in order to be cured for their sake. I sold off my land and my house. Now there is nothing left for them and I am going to die. Why did the doctors do this to me? Now, I know nobody is getting cuts on giving him chemotherapy. Nobody wants to mislead him. But yet, this is how this man felt. So, was informed consent really well informed? He would have been told about the side effects and the cause. So, how do we recommend treatment options in incurable disease? Remember what we talked about financial toxicity earlier. How could we have tried to avoid this communication gap? So, we have to be honest but sensitive. So, often I would say things like when the cancer is in this stage, it is difficult to cure. With medicines, we may be able to reduce it for some months. So, I'm not straight away saying you're going to die in a few months, but we've given a time frame and we've given the limitations of medical treatment. Then we can give them several options as legitimate options. The most recent evidence-based guidelines, some other alternative which is also okay, and also the alternative of supportive care or palliative radiotherapy. Often as doctors, we make the mistake only of giving the very first item. Now, especially when the disease is not curable, it's important not to make that mistake. So sometimes, in fact, I use an example with students. I tell them that suppose you went to the car showroom and you had a choice between buying a Maruti 800 and a Mercedes. Which would you buy? Then suppose 6 months down the line, your Mercedes becomes irreparably damaged. How would you feel? And how would you feel if you realized that the salesman who sold you that Mercedes knew that and still sold it to you? So, if you have that feeling of loss and being cheated with, just an inanimate object and money, how does it feel when patients feel cheated about life and death issues? Now, again, when we give them the options, we also have to tell them the pluses and minuses. In some of these situations, palliative chemotherapy may improve survival by a few months in half the patients. And in those who improve, there may be symptomatic improvement as well. But on the other side, you have treatment toxicity, financial toxicity, time toxicity. So after we have explained prognosis, explained options, and explained pluses and minuses to the patient, what should we do next? Can I have a few answers in the chat box? Okay, let's think. If you were the patient, what would you want to do next? Not in, at this point, you've just heard all these options and this information. What would you do next? Yes, we do want the patient and family to make the choice. That choice may be for palliative care, it may be for chemotherapy, which should be an informed choice. But before he makes the choice, we need to give him time, isn't it? So often I ask the students, how many of you, go to a mobile shop without any previous research and buy it on your first, by what the first salesman tells you? Okay? So give them time. So generally we would tell the patient these are the options and come back to the next OPD, which may be the next day or a day after that. If it is something more urgent than that, you can see them later in the day. But if we don't give them that little bit of time, they can make a hurried choice which they can regret later. Now, can patients, yes, thank you, Dr. Vijay. I'll give them a few days to decide. Can patients have unrealistic expectations even when we have explained the prognosis? Yes or no? I think this will be a unanimous yes, isn't it? Huh? All of us have had at least some patients who have unrealistic expectations even after we have explained the prognosis, and there can be various reasons for that. So another case scenario, this is also a true case scenario that I use, is about a 45-year-old manual worker from a poor background with pancreatic cancer and liver metastasis, who has been told the disease is not curable and that the best chemotherapy would reduce the size of the tumor but not cure it completely. And he's insistent that he wants the treatment and will sell everything and take a big loan. Now, I still remember this patient. This was about 20 years ago. And the patient's wife's brother came and told us that, if he does this, his wife and children will have nothing left. If he sells the house, and she'll be left with the loan, which is going to be very difficult for her to pay. So, what do we do with this patient? How would you approach him? Can we have some answers? Yes, and what would be the first step towards counseling him? So I think my registrars told me that they told the patient, think about your children, huh? Disease is incurable. But then he started getting angry. He said, I want this treatment. Why are you all talking like this? Okay. So again, we go back to what we try to arrange for a sponsor would be appropriate uh, if it was curable disease. If it's not curable disease, the sponsor may be more helpful to the family in terms of providing an employment for the wife or education for the children. You know, the same money could be used in a more worthwhile way. So again, remember when it comes to counseling or when we feel that patients are making decisions that we cannot really understand, okay, acknowledge that. Yes, you want this expensive treatment. Like the previous man, yes, you want to put your father in ICU, you want to help him. What are you hoping for from this? Okay, so that's what I asked him. And then he told me, he said, I know the disease is not going to be cured, but at least if I take the treatment, I'll get to 15 years, and by then my children will grow up. Okay, and then it doesn't matter what happens to me. There are so many diseases in medicine which are not curable: diabetes, hypertension, a lot of chronic illnesses. But you give medicines, HIV, patients go on for years and years. So this poor man thought that if you're talking about such expensive treatments, it will at least work till his children grew up. So it's not that he wanted to harm his family, he actually wanted to help them. So now here is the gap in the informed consent. And I just thought that if I keep saying the same thing, it's not curable, he may not really understand that, because there's also a small element of denial. He can't bear to think that he's going to leave his family unsupported. So then I just, I drew a pencil sketch and I said, see, the cancer is growing like this. Whatever we do not have a way of curing it. Whatever we do, we don't have a way of reducing it for many years. Even with this very expensive treatment, in less than half the people, it may reduce for some months, but after that it will grow again. And without the treatment also, it will be growing. So the difference is only this bit in a proportion of people. So sometimes a picture is better than words. Like, so within 2 minutes, he said, oh, that's all that it is. Then, please discharge me. And I have many things to settle for my family, and give me some pain medicines. So here is a communication scenario, which is also an ethical scenario. So we can ask the students, how do you apply the principles of medical ethics to this case scenario? Would anyone like to put in? What are some ethical principles at stake here? Sorry, I can't hear you well. Could you just put it in the chat box? Yes, so one was autonomy. There was a gap in informed consent. Beneficence. Beneficence versus do no harm. Yeah. Okay. And justice as well, isn't it? Was this an equitable use of resources for a poor family with young children? And we've discussed the same thing when it came to the sponsor. The sponsor has a limited amount of money. Can it go into the children's education, or can it go into 6 months of chemotherapy? Was informed consent truly well informed? Did the benefits of treatment outweigh the burdens? Okay. So these are ethical case discussions, which decisions which doctors and patients have to make multiple times a day. It's not just about stem cell transplants. So this is a statement by an ethicist that whenever we try to help others, we inevitably risk harming them. Healthcare workers who are committed to helping others must therefore consider the principles of beneficence and non-maleficence together and aim at producing net benefit over harm. And we're doing that all the time. And that is why we don't give radiotherapy for benign tumors, because the risks don't outweigh the benefits there. But respecting patient autonomy means that what may constitute benefit for one patient may be harm for another. So if a patient completely believes that he is going to be condemned by God because he receives a blood transfusion and therefore he does not want to put himself at risk for eternity, then I have to respect that. So ethics is not like some, knee hammer where we just tap it on everybody. It has to be individualized to the clinical scenario. And so then I share another case with them. This is another true story of a senior IAS officer who had hormone refractory prostate cancer with bone marrow infiltration. And he and his family wanted to try further chemotherapy. This is many, many years back when there really wasn't anything worthwhile. And we tried explaining that, but they were quite firm about it. And then when we explored further, they told us the reason, that the first grandchild was due a few months later, and they wanted to try and prolong life by at least those few months. So then we went ahead with the chemotherapy. He had a fair bit of toxicity. They spent quite a lot, but he was able to see his grandchild. So now, what is the difference between this scenario and the scenario that we just discussed earlier? Both with incurable disease, both wanting expensive toxic treatments for the sake of their family. But what is the critical difference between the two? One is financial strength, though I have to tell you that this man actually was in a general ward, and it wasn't that they were very, very well off. Yeah. So, like you said, the difference is that he was fully aware of the limited benefits. He knew this was expensive, it may be risky. He was realistic, and we could not guarantee that he would be there till his granddaughter was born, but we could have a realistic hope that he may be there. So I think these questions of weighing benefits and burdens, of clarifying expectations, we have to engage with the individual patient and family and encourage our students to do the same. It's quite a nice recent paper by Varkey and all. See, as doctors, even before we make recommendations, in our own mind, we are thinking, what's the prognosis? What are the options? What are the side effects? Are the risks worth the benefit? If I don't do anything, what will happen? So if I didn't do anything for the breast cancer patient with septicemia, she would die. But if I didn't do anything for the man with pancreatic cancer with liver secondaries, it would not make a worthwhile difference. So as doctors, we are doing this in our own minds, but for the patient, there are various other contextual, cultural, and personal issues which will come into play as well. Okay? So what is a good quality of life for one person may be very different for another. Especially often you see elderly people say, no, I've lived my life, now I don't want to go around hospital. Whereas a young man may be desperately putting up with side effects of treatment. the hope that it would help his family. We've already talked about contextual factors. So recently, our college day play that we did was a legal drama. So then, recently when I took a class on ethics for the students, I showed them these two pictures. And what is the difference in attitude between these two statues? Can someone put an answer into the chat box? Okay, just look at the head carefully. What's the difference between the two? That's right. So the difference is the blindfold. Okay. So when we practice medicine and when we apply ethics, we should not be blind to individual preferences, anxieties, context. And one of you said the second one seems more welcoming and open-minded. That's right. Huh? We should not be authoritarian with us, with the sword of our stethoscope. We should practice medicine with respect, humility, and empathy. But the yes is that we should weigh benefits and burdens, autonomy and justice. So that was a little bit about ethics. So, we are going through three huge topics in one afternoon. Now, very briefly about communication. So communication skills, a lecture is definitely not the best way of teaching it. Role plays are interesting, but my only caution is that make sure that the facilitator does the demonstration good role play and don't spend too much time on the bad role plays, because bad role plays will be like films and the students will remember that. The main thing that we want is to show them the good role plays. And if you have good videos, that's often very helpful. We also did some faculty development workshops so that the mainstream teaching departments could teach communication in their context. That carries a lot more credibility. And back in 2007, we held a national workshop on communication skills in clinical medicine and put in some of the key factors there. And we're really happy that ADCOM is now a part of the national curriculum. Now, most of us would have in palliative care learnt about the steps of breaking bad news. But another important thing, because remember, a fourth year medical student may not be immediately breaking bad news, is about gathering and giving information. Okay? And that applies to curable, acute, all kinds of illnesses. So we're going to share a video with you. And before we do that, can anyone write what is ICE in terms of communication? And as you watch the video, watch out for the ICE. Watch out for two important principles in sharing information and at least one ethical issue in this consultation. So in this video, we focused actually on gathering and giving information. In a way, it was almost breaking good news rather than bad news. What were two principles of giving information? We used two words there. Did anyone notice? Both started with C. chunk and check. Okay? It's like you give a child, you give a bit of information and then you see if they have understood it. Like we know if we have a lecture where the lecturer just keeps talking, very little will stay. So chunk and check is a good thing about give a bite-sized piece of information. And then I asked him, what will you do when you come back after 3 days? And there were various other principles as well. An analogy is often helpful. Saying point 1, point 2, point 3 is helpful. Knowing where the communication gap is very, very important. We have only very few minutes left. Any questions, comments, suggestions? Thank you. Yeah, I would actually like this video to be used. It's been delayed a bit. I just have to edit it because, as you can see, in some places the words are not visible. And I thought it would be nice for us to combine it with a Google form about what students know, what they find helpful, what they don't. So can we do that, Shri Priya?
Ma'am, you want us to add Google form to it and send?
And I'll make a Google form. I just needed it edited a little bit so that those things are not getting cut off,
Sure, ma'am. If you provide us the material, we can definitely do that.
You'd be able to do that? Okay, because the person who used to help me is no longer here and that's why this got delayed. And any of your FDP people who would like to use it along with the Google form, it would be nice if we can.
Sure.
Thank you. I'm glad you like the video. The patient is a vascular surgeon. He's a professor of vascular surgery. I will convey your remarks to him and all the best. And thank you so much for your active participation.
Is there any questions or comments before we close? As soon as we get the video, we try to edit whatever madam wants and then we'll circulate. We'll upload that in the LMS so that you have access to it, or we'll try to share it as a link probably to all of you. If there are no more questions, we can wind up today's session. It was very interactive. It was very interesting to see the interactions.
Madam, in the chat box, I had asked a question. If the person refuses to accept the inevitability of his situation, then how can we guide him further if he's not ready to accept?
Yes, so that's a fairly common problem. Now, denial is often a protective mechanism. Okay? So the first thing we have to see is the denial causing harm.
Okay.
So if, for example, he says, to prove you wrong, I'm going to take 20 lakh loan and start a new business tomorrow, then one thing, of course, would be to talk to a responsible family member. The other thing would be to say a hypothetical situation. Now, suppose things worked out badly, then what would happen to your family with the 20 lakh loan? Sometimes people are able to engage with a hypothetical situation. Or you can say that, okay, suppose your friend, not you, but if your friend had an illness which was incurable, and if he was going to take a 20 lakh loan, what would you tell him?
Okay.
Most of the time, when people are not accepting prognosis, the vast majority are not doing things that are harming themselves. They'll say, no, I don't believe the doctors, but at some level, they're not making decisions that are harmful to themselves. So if that's the case, then we can give them time.
Okay.
We can say that, if you want to discuss further, we can discuss at a later date. Not everybody is able to get all the hard facts immediately, and we don't have to push it on them then.
Okay. Yeah. Thank you.
We have one more question. Some people are scared or misinformed by some other people. How to go out with a person who's making a wrong choice based on wrong information? Yeah, again, with all of these things, a good principle is first to listen to their perspective. What are your ideas? What are your concerns? What are your expectations? What do you think about the disease? Why are you choosing this treatment option? And what are you expecting from it? So if we have explored, then we can find where the key communication gap is, and then we can know where to begin addressing that. If we don't do that, then we will start at another end of the story, and more we will become in opposition to each other. The other thing also is that the patient has to respect that you know the subject and that you are committed to his welfare. If you have got that foundation right, then they're again more ready to trust you. Right, then it's quite late in the evening, so thank you all for remaining engaged, and all the best with your new initiatives.
Thank you so
Thank you
much.
very much.
Thank you all the participants and the questions and the interactions. Thank you so much.
Thank you, Reena ma'am. Thank you so much. Every session of yours is a new learning, even though we are listening it for multiple times. Each session becomes more and more of a learning for us as well. Thank you so much. Thank you, every participant, for making the interactions live. And before we log off, just a couple of important updates to be given. Like, we have already formed the small groups for discussions regarding the group activity. The link to join the small groups is already shared in the WhatsApp group. Please do look out for your respective groups and join the groups without fail. And we'll be sharing the topics. Which topic is to be worked upon by which group, the topics will be given by today late evening. So please do pay attention to that as well. And we have also uploaded all the learning contents as we have promised for the upcoming activities. Regarding pain and communication skills, we have uploaded the drive link as explained yesterday into the iEcho platform. So now all the learning materials are easily accessible to you. So please do make use of that. You have a weekend ahead. Of course, I could not say that have a relaxed weekend, because we really hope that you will utilize your time to go through all the materials and come prepared on Monday when we meet again with an exciting activity in place. Till that time, this is Ripriya along with Dr. Reena George and Dr. Sridevi Warrior signing off from the Tipseco. See you on Monday. Till then, everyone, take care. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.